everyone, and welcome to another episode of MedSynapse podcast series, where we bring you insightful conversations with leading experts in healthcare. And today we are diving into a fascinating topic, which is acute care bronchoscopy skills by the intensivist himself. Joining us today is a distinguished guest, Dr. Manish Bharti, a seasoned consultant and interventional intensivist with over 15 years of experience. Dr. Manish has been instrumental in advancing acute care medicine in India, including spearheading programs to enhance bronchoscopic skills for intensivists. So that makes him the perfect guest for today's topic. He's also the recipient of ISCCM President Citation Award 2023 and the Times Now Promising Intensivist accolade for 2024. So Dr. Manish, welcome to the show, and it is a pleasure to have you with us.
Thank you, Hitvi, and thank you, Team MedSynapse, for having me here. It's a wonderful day, and it's an exciting moment for me to share my passion with you with respect to the intensive care medicine, that how the things are changing in intensive care medicine when it comes to this country. And I'm going to share in the next couple of minutes through this discourse, which I'm going to have with you, Hitvi, that what is the fate of intensive care medicine and how the intensive care medicine is getting evolved in India. And apart from what new things which we have added by having an experience from outside country, from Middle East, from West. So the conglomeration of all those kind of things we are going to share on this platform. So thank you, Hitvi. And once again, thank you, MedSynapse, for having me here. Yeah, please go ahead, Hitvi.
Yeah, thank you so much, doctor. And we are so excited to hear about intensive care, particularly by you. So now let's just start with an overview, doctor. So bronchoscopy is often, seen as a crucial tool in acute care settings. So could you share how this procedure has evolved in critical care and why it is becoming a must-have skill for intensivists?
Okay, so thank you. It's a very crucial question. I must say, Hetvi, this question is so prudent for us to understand that, if you talk about, let's say, 20 years back, the critical care medicine was not something which used to exist in this country.
Mm-hmm.
Now, it used to be practiced by, the people from different fraternities. But keeping in view that medical science is evolving, so obviously now you have people who are trained specifically in intensive care medicine. Now, what do you mean by intensive care medicine or critical care medicine? So critical care medicine is a branch, especially we have realized after the COVID, right? Because the COVID has given us the opportunity where we got visible in terms of intensive care medicine. So these are the doctors who have been trained specifically to treat, to understand, and to diagnose and to manage the patients who are acutely sick. Now, what do you mean by acutely sick? Acutely sick means, for example, the gentleman who was otherwise ill and hearty suddenly has gone through, let's say, pneumonia. The pneumonia has got worsened, the chest infection, and now the patient requires to be on ventilation. So now you have people who are actually expert, who understand the interaction between the patient and the ventilator, the machine, and the human beings, and they can actually design the best optimal treatment plan. And of course, when you know the best, then there is a possibility that you can give us the best possible outcome as well, right? That is what basically. Now, when it comes to intensive care bronchoscopy skills, now this is a new thing which we have added, and this is through my mentor. His name is Dr. Tushira Virabonna. He's basically the director of lung center at Forheim, Germany. We met through one of the meetings, which is basically European meetings, which we used to attend in this country. It is by the name of Eurasia, right? So the Europeans, the West people, the East people, they interact on a one common platform, and they reach us to the best possible practices. And how can you get through these practices in this country? Now, when we were interacting through this platform, we realized that this is one thing which is a need of the hour. Now, what exactly it's in acute care bronchoscopy skills? Now, when the patient, especially in the COVID, Hitvi, what we have realized, when the patient who is coming in the ICU and having issues with the lung, right? So there is a windpipe, and then this windpipe goes into the two lungs. And there used to be a lot of phlegm burden. There used to have a lot of secretions. They used to have a lot of mucus plugs. So these are basically, the things which get complicated in pneumonia. Now, when you do the bronchoscopy in them, now what do you mean by bronchoscopy? Bronchoscopy is nothing. It's basically a pipe. It's a hose, right, which has a camera channel. And this camera channel through this pipe has to go through either the nose or through the mouth into the patient windpipe, right? And when it gets into the windpipe, we are actually able to see what exactly is the problem in the patient windpipe or in the lungs. And depending upon the problem, we target the treatment. So it's like, seeing it and doing it and believing it. And this kind of things, this could happen possible. Now, why this is the need of the hour? Hetvi, we need to understand the patients who are in ICU, they are very sick. They're very brittle. They are like, the moment you go haywire, slightly something happens to this, we eventually lose them. Now, the training has to match, the training for the doctors has to match according to the severity of the disease. Now, because it never used to happen in this country, so of course, we were not having an expert for those subjects. Now, through this program, what we have realized, now we are training the doctors specifically to deal with the sickest of patients, the patients who are very sick, very brittle, right? And we train them into this skill so that the patient should not lose that window, that golden hour through which we can make them survive. So this is basically an acute care bronchoscopy skills. And we are proud to say, we established first international training center for the doctors to train in this beautiful skill, which is very, very difficult otherwise to master, in collaboration with Richard Wolf Academy, Germany, which is the one, the major, I would say the program which is happening in the Germany, because the bronchoscopy skills has originated primarily from the Germany, right? So we collaborated with them and we established the first international training center in this country for the doctors of, the intensive care. And now I'm providing my services to Yatharth Group of Hospitals, which is in Greater Noida, Uttar Pradesh. And we are now on to the part where we establish another center. So through this program, we have been able to train the doctors not only in the central part of the country where I'm living, also the northern part. South, we established 4 centers and 3 centers in the east as well. So this is where, our program, just wanted to give you the legend about our program. And of course, we can go ahead with further fine details. Please go ahead.
That's really interesting to know your entire program also and how widely it is expanding as well. So really interesting to know. So now, Doctor, could you elaborate on how actually bronchoscopy aids in managing conditions like acute respiratory distress syndrome or other critical respiratory challenges? Because as you also mentioned that in ICU it becomes very critical and the patients are really critical. So how do you manage those?
Thank you for asking such a crucial question, Hetvi. And it's a very valid question. Nowadays, by the virtue that, the knowledge is easily accessible. If you put it onto the Google platform, you find so many things. So, in this, I would say the information pandemic, whenever the people, they come to us, of course, they know a lot about the disease by default, right? Whether it's an ARDS, it's very good. You came out with this word ARDS. 20 years back, people only from the medical fraternity, they used to speak this language. So now even a person from relatively, who has not been dealing with intensive care, like you can be able to understand. So that is where the blessing lies for, what we are acquiring through the artificial intelligence and all these things, right? Having said so, the point which we need to understand, especially after the COVID pandemic, in fact, during the COVID pandemic, we realized, Hetvi, that many of the patients, they were not dying because of the COVID disease per se. They were dying because of the mucus plugs. Now, what is mucus plugs? Whenever you have any chest infection, we tend to have phlegm. We tend to have, this sputum inside which gets stuck. Now, if you are healthy, you will be able to expectorate. Now, when you are very sick, you cannot expectorate. Now, see the irony of the disease. The patient drown into his own secretions. Just imagine. So in the COVID pandemic, Hetvi, what we realized, that the patient, they were not dying actually because of COVID disease or COVID illness. They were dying because of this sputum burden or the phlegm burden, which used to get stuck inside the windpipe. And obviously, it's like a pipe which is getting choked.
Yeah.
So if you have a choked pipe, how can you allow, and how is it actually possible for the patient to breathe here? You need to have a free, the conduit through which you are going to breathe, right? Now, during that time, I was in Kingdom of Saudi Arabia and I was heading the Prince Sultan Cardiac Center as a chairman in critical care medicine. And there I had the opportunity to scope these patients, to do the bronchoscopy for them. And we realized, Hetvi, which was very surprising, and we then came out with the papers and recommendation that many of them who were actually supposed to die because COVID was taken as a bad illness, they actually started living when we started doing bronchoscopy, right? We discovered they were having plugs, they were having this phlegm which got stuck, and the moment we used to take it out, the patient used to survive, right? So COVID, why I'm giving you example of COVID, because COVID is something through which everybody connects. Okay, so Hetvi, during that COVID pandemic, why it is important, why it is relevant, because we can connect easily through the COVID disease. Almost everybody, there's no family which I know who has not been dealing with either their family member for the COVID illness, or they themselves, or somebody who is in the vicinity of them, right? So COVID has given us a lot of wisdom, a lot of learning related to it. And that is why, we need to understand why. So COVID is a disease which gives you an ARDS, right? So when you talk about ARDS, so ARDS is an acute respiratory distress syndrome. It's a disease which causes the stiff lungs. The lungs, which are otherwise quite elastic, they become very stiff, right? Now, we discovered that actually they were stiff not because of that the lungs were bad. It is because the area through which the gases has to go, they were choked, right? So what is important to understand that even the patient who has a lung disease, right, their lungs are affected because of an ARDS, but still the mechanism of gases, the gases has to go through the windpipe. If this area is choked, then obviously it is difficult for them to breathe. Now, it is quite intuitive to understand if you remove the secretions on this part, right, then you give a better chance for the lungs to recover and heal. So ARDS is a disease which is very bad disease, very tough disease for the lung. Even this disease get complicated by choking of the windpipe, the trachea, which we call it as, because of the secretions, because of the phlegm, because of the mucus, because of the sputum. And that is how we used to help them to breathe better and to heal better, right? So that is where, the role of bronchoscopy lies, especially in ARDS. Many of the patients, Hetvi, we thought during the COVID illness that, they are having infection apart from COVID, some bacterial infection, which tend to happen for any patient who is having a long stay in the ICU. And through the bronchoscopy, when we have taken off the secretions, we used to send it for investigation. And then we realized that it is not actually the infection, it is just the mucus plugs which are sterile. So the reason I'm sharing with you, so that you can understand that even the disease which is as bad as ARDS, it's also get complicated by the secretion, the phlegm, which are easily retrievable through this bronchoscopy. Now, obviously, it requires a lot of expertise. Why? Because, just imagine, you're driving a car in a road which is choked. So you must be an expert, right? If you have too much of traffic on any given a narrow road, then obviously there's a high chances you will hit to some or another person, right? And chances of injury will increase. So something like this, we understood through our experiences, and that gave us the opportunity. Yes, the people need to be trained in this exercise, in performing this scopy, and make the situation better for the patients, either whether it is because of COVID or even if it is because of any other illness, right, which is leading to ARDS.
Yes, I think that is so impactful also, Doctor. And you have partially also answered my next question, which was like for intensivists looking to acquire these skills, what key competencies should they focus on? And how can simulation-based training play a role in their learning?
Yeah. So another important question, the point is that knowing is not enough, because we know so many things. Everybody knows that exercise is good, but many of us, we don't exercise. Everybody knows smoking is bad, but still people, right? Alcohol is bad. So the reason why I'm telling you, because now we have understood, okay, bronchoscopy can change the game of these sick patients. There's no doubt. But unless and until you know how to walk on the tightrope, you may not be able to help this patient, right? So these are very precariously placed patients, very sick, very brittle, because if you're making an error in them, it is going to cost you either the life or death, right? So the situation is always in ICU is between life and death. Your patient are very fragile. So obviously the training has to be done through the mentorship of the mentors who are expert in the subject. And that is why we are promulgating this program. And uh, in our center, we give them a direct experience. Now, what do you mean by direct experience? They come, they stay with us, right? They understand that how we are performing these skills, right? They are going to be stationed like an observer. And then eventually, when they spend maybe 30, 40 cases with us, then they have the opportunity to actually do it onto the real patient. Because it's always that first you have to observe it, right? Observe it. So you have to observe it to the intricacies, all those kind of nuances which the people have to discover. And then eventually, they do this skill under the guidance, under the observance, and then eventually they are ready for the independent. Now, this is one part of the training. The second part of the training, which we endorse in the workshop, is through simulation. What is simulation? Simulation is you create real scenarios, almost in a real mannequins. They are the mannequins which sounds exactly like the human bodies and the human trachea, human windpipe, and human lungs, and we make them perform this exercise under the controlled condition, right? So we give them the case scenarios. They do it under the camera cover, and of course, they can understand where they are making a mistake. So the best thing is that they learn actually not on the patients, but onto the mannequins, which give them a real kind of a experience. And once they go through with this, then eventually they are ready to perform the same things in the patient as well. So two kind of a training things which we are providing. One, simulation, and the second is real experience on the patients, when first they have to do it with us under our observance, and then eventually they are ready for the next step.
Yes, I think this such intensive training is also really necessary when you do such a minute kind of simulation-based training, especially, and it sounds like such a game changer, I feel.
Yeah. No, there's no doubt. There's no doubt, as you said, intensive care training, if you really go by the meaning of intensive, it means small things. When you add them together, they become the big things. Correct. We always believe. And intensive care is one where even the smallest of mistake, although it looks very benign at the outset, but it has a potential to change the game of the patient.
True. Yeah. And I think it does require such intensive training also for all the physicians. Yes.
We have a dedicated training programs for intensive care. 15 years back, there was no training programs. When I joined, we just started, this country just started with the training in this specific subject. And now you have a DM curriculum. The DM is the highest degree available in this country. Even the DM is available, but still, there is a long way to go, because when I compare it from West, King College, where I had an opportunity to work for my liver intensive care program, and whether I'm talking about Kingdom of Saudi Arabia, Riyadh, Prince Sultan Cardiac Center, there we had a lot of experience. So there is a wide gap which this country needs.
Definitely. And I think with some time, that gap will also be filled, I feel.
For sure.
There are so many benefits, and those benefits are clear, like performing bronchoscopy in critically ill patients must also come with its challenges. So what are the primary hurdles intensivists face, and how can these be effectively addressed?
So the biggest challenge which I see, Hitvi, is that first of all, anything which comes new to the system first has to go through the process of rejection. So right now, when I'm working in a society, everybody's rejecting, no, this is being done by the pulmonologist. Now, pulmonologists are the people who are trained in pulmonology care, the lung care, right? Now, the area where we are debating, and it's a matter of debate, and I think eventually people will accept it, that pulmonologists are the people who are expert in dealing with the patient with the lung issues. But there's a difference between, pure pulmonology case and when the patient is admitted in ICU. Patient profile is different, right? So when the patient is in ICU, the patient is going through complex changes in the physiology, where the heart is working in a different pattern. Lungs, they are already squeezed because of ARDS or something like pneumonia. Kidney is also not working. So what I'm trying to make you understand, that there is a lot complexity attached to a patient who is there in ICU, right? And of course, intensivists, like my profile is intensivist. I'm not sure that how many people actually even know what is intensivist, right? Everybody knows cardiologist, nephrologist, gastroenterologist, but people don't even know who is intensivist. So intensivists are the people who are trained in intensive care medicine, and it's basically a super specialty qualification. And they're the people who are specifically trained to handle the patients who are in ICU. Many of the institutions, they don't even hire the people from intensive care. So there's a wide gap. That is one of the biggest challenge. The second, as I shared with you, because at least in this country, which I'm seeing, I'm working in the capital, almost in the capital. If I'm having a challenges here, I can expect the challenges in the remote areas as well. So pulmonologist people, with all respect, love, and gratitude to them, they have been taking care of the patient with lungs. But now we have people who are trained specifically to deal with the sickest patient in terms of the training. They're much more organized, they're much more laborious, they're much more dedicated. They are standing bedside to the ICU patient, and they can intervene and relieve the situation much faster. So that golden hour which we are talking about, golden hour is the time when the patient is sick and it has to be acutely managed, right? Because if you don't manage in golden hour, you will lose the patient. Now these people, they are intensivists and they need to be there for this bronchoscopy program. So challenges which we are facing is that this bronchoscopy program is still not a part of, like you are seeing my background, which is Indian Society of Critical Care Medicine. So I'm an active member of ICCM, but still bronchoscopy program is not a standard part of even this society. And the biggest resistance which I face is through the pulmonologist. So through MedSynapse, I'm fighting my own struggle. So because my basic specialty is from anesthesiology and intensive care practice, and then I reaches to this new super specialty in the form of critical care medicine. So people will take time to accept, right? It has to go through its own phase. Eventually it will be accepted, there's no doubt. But right now we are in a phase where the more rejections are there, more reservations are there, and eventually, it's the process of time. So this is the biggest challenge which I'm saying. The second challenge which I'm anticipating, even if you are there intensivist. So Hitvi, not everybody who is from intensive care medicine is trained in bronchoscopy skills. As I said, it is not a part of training. So it doesn't mean that if you're intensivist, you should start doing bronchoscopy. There has to be intensivist, but the intensivist also has to be trained in this skill, right? Like my training is there from Germany. So those kind of trainings has to be there with them, attached to their experience, and then they can provide with the safest video. So that is the second challenge. Third, because it has not been accepted in the society yet, we are not expecting too many training centers right now. The only training centers which we have established, we are the pioneers. As I said, with Richard Wolf Academy, Germany, where my mentor, Dr. Tushira Veeravarna and Dr. Rajesh Chandra Mishra. Third is Dr. Sumera Makbul Tantre and, Dr. Lopa from Bangladesh. So we have the expert from Indonesia, India, Germany, and Saudi Arabia. So these are all people who are basically aligning themselves together in this mission, because I spoke in Indonesia on this and people have been able to accept it beautifully. It has been accepted. And the irony, Hetri, we are getting more accepted outside the country rather than in this country for this skill. Just imagine sharing something, on the lighter side. Yeah. More people are calling from outside this country to introduce this skill, and our own country, India has the biggest reservation.
Yeah, so these are the challenges. So many challenges to overcome also. And I think you also mentioned that with time, I think it's just a matter of time, and with time it also progresses. So let's hope for the best. So now, Doctor, you had a remarkable journey, and no doubt you have also witnessed so many cases where bronchoscopy made a significant difference. So could you share like a real life example where this skill dramatically improved patient outcomes?
Yeah, if you can, just a couple of minutes I was sharing with you. See, I have a list of almost 1,200 cases which I have prepared as a compendium. And I speak in ICC meetings, I speak in state meetings, I speak in national, international forums. Wherever I go, I share those cases. Now, obviously, this platform may not allow me to share that case right now because it requires me to present it, right? So it takes time. And in case if you agree, we can definitely hold one, maybe a meeting where I can show
Sure.
you through the case, how the case is evolving. But as I shared with you, that COVID cases which we were having, they used to die initially. And in the second wave of COVID pandemic, we realized now they're surviving. And the difference is obviously the better understanding of the disease. But apart from this, the better care, which we were able to give in the form of acute care bronchoscopy skills, right? So these are the real cases, 1,200 cases, which I gathered from my previous organization. And thanks to the previous organization, I was there with one of the very profound medical college, Shada Hospital, Shada Medical College and Shada University. It's a big university in northern part of this country in Uttar Pradesh. And there I had this 1,200 cases compendium, and we realized that we were able to reduce the death rate of the patient from 40% when I joined the hospital to less than 10%. So just imagine people, well, 4 out of the 10, they used to die previously, and now less than 1 out of the 10 used to die. So that is so much of change which we were able to make an impact. Not only this, Hetvi, we are now sitting in the antibiotic resistance era. So it's an antimicrobial resistance. Now, what is antimicrobial resistance? You have seen in this country, everybody's popping the pills, right? Takes antibiotics, like for even a small illness, they need antibiotic. Because of which we are developing a lot of resistance, which means the antibiotics which used to work previously for the given infection will stop working. So you need stronger antibiotics. And because now you need a stronger, the resistance, the bugs, the bacteria, they're very smart. They develop resistance to it, and so that they can survive. Now, the reason I'm sharing with you, because when you use bronchoscopy skills in sick patients, right, you can not only decrease the death, as I shared, because of mucus plugs, phlegm, plus you can also reduce the consumption of antibiotics. Why? Because patient, when they breathe better, and the collection of the sputum is less inside the patient lungs, it becomes easy for them to have recovery. So you're using less doses of antibiotics, less duration of antibiotics, and less higher antibiotics needed by them. So eventually it makes a lot of advantage, right?
Yes, that's
So
really
that is where,
inspiring. Yeah. So, Doctor, before we wrap up, one last question would be, if you could provide one key takeaway for intensivists aiming to integrate bronchoscopy into their practice, what would that be?
Hetvi, I'm a ISKCON devotee, International Society of Krishna Consciousness. It's my heartful wish that everybody from intensive care should be trained in this acute care bronchoscopy skills, so that our trusted patients who are coming to us, and we can save them, we can actually do justice to their care. So each intensivist should train one more intensivist in this skill. So I'm not sure when we are going to achieve this mission, but this mission of acute care bronchoscopy skills for the intensivist, by the intensivist, is something which I envision, and I wish through you, through this medium, and through the blessings of Lord Krishna, we should be able to achieve it. If not now, then at least by maybe a decade or something, we will meet again, and hopefully we will be discussing about the advances which we are doing now in acute care bronchoscopy skills. So that is what I wanted to give it as a last message.
Yes, that's really inspiring also, Doctor. So thank you so much, Doctor, for sharing your expertise and experiences with us. Actually, your insights were so truly shed light on its critical role in actually modern intensive care. So thank you so much for sharing that.
Thank you, Hitvi. Thank you. Thank you once again, Hitvi, specifically to you for navigating this discussion flawlessly. And I'm really happy that now you can speak intensivist, acute care bronchoscopy skills. You understand so many terminologies. And of course, Akshay, who has been there behind all of the curtains, was just taking care of, how to come out from recording and giving us the best possible videos for everyone to understand, to learn. And last but not the least, the Indian Society of Critical Care Medicine, which has given me this platform to reach to this level. And of course, MedSynapse for having us together and sharing this mission, vision together with the intention that 10 years down the line, we will be in the best of medical sciences. Thank you.
Thank you so much for your kind words, Doctor.
Thank
And
you.
to
Thank you.
our listeners, I hope you found today's discussion as enlightening as I have. And remember, innovation and continuous learning are the pillars of progress in healthcare. And if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay curious and keep making a difference.